Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant. This podcast is produced and edited by the Milk Mob and is co-sponsored by the Academy of Breastfeeding Medicine. Are you ready to go? Hey everyone, this is Ann here with the podcast, and I'm talking with Dr. Katrina Mitchell. Dr. Mitchell is actually a breast surgeon with an MD Anderson affiliate hospital in Albuquerque, New Mexico. She's also an assistant professor of surgery at the University of New Mexico, and she has a special interest in lactation, and we have a lot to learn from her. Hey Katrina, how are you?
Good.
Good.
Staying cool inside.
Thanks for joining me on this podcast. Are you thankful because it's really hot in Albuquerque right now?
Oh my gosh, it's over 100 degrees. I don't know what Wisconsin's like, but
oh man, that's bad. Man, bad for everyone, even nursing mothers and babies.
Yeah.
So
yeah.
So you know what I thought I would do today is, rather than having you give a huge discourse on like breast masses and lactation and all this stuff, I thought I would just present a case, because I had this really interesting case, and I thought we could use this case to like talk about how to work up a woman with a mass who's breastfeeding and all the things to think about, and maybe explain a little bit about the way that radiologists describe these lesions and how to interpret those things. So, and I'll bring up the description of the radiologic findings in the case that I present to you. So how does that sound?
That sounds good, and I'll try to not feel like I'm taking the oral boards.
Oh, it's just practice for your IBCLC. Yeah. Okay, so here's a case. So there is a healthy 28-year-old mother who's breastfeeding her first child. She had a normal pregnancy and an uneventful labor and delivery at 39 weeks gestation, and her infant was born at 8 pounds 15 ounces. So everything seemed pretty normal. The baby nursed well postpartum, but she had some cracks and scabs at the time of hospital discharge, and the baby always was gaining weight well, so there's never really a concern about milk supply. She was first seen by you. Let's say that you're the doctor, the breastfeeding doctor, at 2 weeks postpartum, and she had persistent cracks and severe deep breast pain after nursing. You worked on her latch, and the latch improved, and she was very happy. She felt like it didn't hurt as much to nurse the baby, and you gave her some antibiotics because you thought she had a low-grade infection based on the degree of pain and how nasty her cracks and her cracks and scabs looked on her nipples. So in the next 3 weeks, all of her symptoms resolved, and her milk supply seemed pretty well matched. She didn't really have like excessive milk, and the baby was gaining well. So you said, goodbye, see you later, call me if you have any problems. So 3 weeks later, she suddenly notices a very obvious lump in her right breast. It kind of happened suddenly, and she calls her doctor, not you, but she called her doctor, after it had been there for 2 weeks. So at that time, she told her doctor that she didn't have a fever, redness, or warmth of her breast, and it really wasn't very tender. Her milk supply wasn't really changing in that right breast where she had the mass. Her primary care physician described in her notes that she identified it as a 2 by 2 centimeter mass at 9 o'clock in the right breast. The mother didn't have any adenopathy, and so she sent the mother for imaging. So she had, as routine at our breast center, where I am at the University of Wisconsin, she had a routine mammogram and an ultrasound on this mass. So her mammography showed a right breast mass in the middle of the right breast at the 930 position, about 6 centimeters from the nipple, and they thought it was a galactocele. They described it as a 4A, which meant suspicious finding, and they recommended an ultrasound to do a diagnostic aspiration to confirm that's a galactocele. And if they couldn't withdraw any fluid, they recommended that it be biopsied. And they categorized it as a BI-RADS 4, which meant low suspicion for malignancy. They also did.
That's a 4A, so.
That's a 4A. Oh,
just
that's a 4A.
I want to
Oh,
make
okay.
sure, yeah, that
Because it was like, okay.
so a 4 has 4A, 4B, and 4C. So a 4A is a low suspicion for malignancy, 4B is moderate, and 4C is high.
Got it. Okay.
So there are some gradations within category 4.
Okay, because they said on the report that it was like, first they said 4A, and then later they said BI-RADS.
Yes.
So I see. Okay. So then.
Yes. So the 4A is that's appropriate probably for a complicated galactocele.
Okay.
Or potentially a 3. Yeah.
So then they also did an ultrasound at that same time, and they described it as a 24 millimeter by 18 millimeter by 19 millimeter oval heterogeneous mass with indistinct margins with posterior shadowing in the right breast at 9:30, 6 centimeters from the nipple. So they kind of got better measurements of the size of it on the ultrasound.
Mm-hmm.
Didn't have any calcifications or other findings. And then they aspirated it using an 18 gauge needle. And they got 2 mLs of milky fluid extracted from that area. So then they said, aha, there's milk, and so that must be a galactocele. So then over the next 2 weeks, so then she was told, that's a galactocele, see you later, don't worry about it. So over the next 2 weeks, she really didn't have any follow-up with anyone. So, and the mass seemed to grow and it became somewhat tender. So she called her doctor, and the doctor said, go back and have another ultrasound done. And oh, by the way, go see the specialist in the breast center as well. So, so at that time, the provider in the breast center felt it, said, let's do another ultrasound. They didn't repeat the mammogram. The ultrasound showed that it was somewhat bigger, up to 31 millimeters from the largest size of 24 millimeter. The largest measurement was 24 millimeter last time. So it increased a little bit. And then they did another aspiration and they got 6 ml. And she never felt like it went down completely, and it felt a little bit better. But then the breast center said, go see a breastfeeding medicine specialist, who is now going to be you, Katrina. So she's referred to you, or the same, let's say that you're the one who saw her. Also, you're the one who saw her at that 2-week mark as well. So now it's 9 days after the second aspiration. And when you feel the mass, it's golf ball size, it's firm, it's not tender, there's no fluctuance, there's no induration, so it's not like thickened, warm, red. You look at her breast and it looks like someone stuffed a golf ball in her breast, but it doesn't really look like it's infected. And she's not really super bothered by it. So what would you do at this point?
Well, I think this is not the most straightforward situation. I think that I'd like to see the images myself. I think that's really important, because if they're calling it a likely galactocele, these galactoceles aren't always simple. They can look more complex on imaging, which is why I imagine they probably gave it a 4A, and they did describe it as heterogeneous. But if they got milk from it to begin with, they got milk, they got 6 mLs for a 3 centimeter galactocele, you may expect a little bit more fluid from an aspiration. But then again, if it's partially calcified and the milk is getting really thick and sticky, it may not be a very effective aspiration. So at that point, I would probably want to do another ultrasound guided aspiration to see if I could get it to collapse down at all. I mean, I think these are, as I was saying, the general surgery boards, and even what you learn in breast surgery fellowship, things are a lot more straightforward. Either you're seeing an abscess or you're seeing a simple galactocele, which is just a cystic mass filled with fluid that's a simple fluid. But really in practice, I think you see situations like this where it becomes more complicated, and the mass may be more heterogeneous, it may become more irregular over time. And I don't think we have that particularly well defined, except to call it a complex galactocele. So I would probably, if I saw this patient, I would aspirate again under ultrasound guidance, take another look at the mass and see what I got out.
So let's say, so at what point would you decide that you would biopsy this mass? Like to make sure that you're not dealing with a cancer? Like, is there anything that would, like, would you ever do that?
I think absolutely biopsying any kind of mass that is not resolving is never the wrong answer. I mean, you never want to miss a cancer, but this is a 28-year-old mother. I assume she probably doesn't have a strong family history of cancer. If you're not giving me that, she had previous nipple trauma and subacute mastitis. So it sounds to me like this is probably a fairly straightforward plugging turning into a galactocele situation where they did aspirate milk. But if there's any concern for a mass becoming more vascular or more heterogeneous or more irregular with concerning ultrasound findings, it's never ever wrong to core that, because you're putting in the same size needle for a core needle biopsy as you are to aspirate milk.
Oh, so the core biopsy needle is like 18, is it an 18 gauge?
14.
Oh,
yeah,
14.
I mean, it can be a 14. I mean, 16 sometimes. But essentially, it's the same kind of defect. And so if there's any kind of concerns, I'd have to kind of see the patient, see the imaging, look at it clinically. There may be there may be something that suggests there was a little bit of a nidus for kind of a chronic mastitis superimposed on a galactocele. I think these are really kind of overlapping. They can be overlapping diagnoses, and I think that's probably not helpful for clarifying things for people, but it really isn't quite as black and white as I think I used to understand things as a general surgery resident or even in my breast surgery training.
Mm-hmm. Yeah, it seems like these are just totally gray. And so this patient went on to have a biopsy of the lesion, and the pathology was described as benign fragments of inflamed breast parenchyma and cystic content. And so then she, like, what's interesting is about, so I guess to reveal the truth is that I did see this patient. And so, so let's say that you talk to the patient, let's say I did, and let's say you did, and you talk to the patient like 6 days later to see how she's doing. And she says, well, I kind of feel like it's going down in size. So then at what, like, would you, in this situation, still, keeping in mind this concern about breast cancer, since breast cancer is so common, would you follow this lesion over time to make sure it totally resolves, or would you feel comfortable just saying, let me know if it doesn't go away completely at some point?
I would follow this. I think most breast surgeons out there, well, I guess I can't really speak for everyone, but I think in general, we tend to follow lesions even outside of breastfeeding. So if someone has something like a fibroadenoma, which is a common benign breast mass that occurs in young women most of the time, we generally don't excise these unless they are larger than 2 centimeters, growing, something is changing, the patient is really symptomatic. But it's something that we would follow every 6 months for usually 2 years to ensure that it's not changing. So I do think most of us like to follow things. And personally, with these patients, particularly if they're older, there's a family history of cancer, I'm more suspicious for something more sinister hiding in there and kind of serving as a point of obstruction to begin with. I like to follow them with imaging at least every 6 months, and sometimes in the more acute period, I will follow them up at the 3-month mark with an ultrasound and an exam, because I think you need to ensure that that area has resolved and that there isn't an occult mass hiding in that area. I think that's uncommon, but our goal is to always not miss a cancer, not miss a concerning lesion. So So that's how I would follow.
Interesting. Well, I thought, so, sometimes like when you biopsy something, particularly I know from just as a family doctor, biopsying the skin lesion, like an actinic keratosis, can actually help to make it go away. Or if you like inject candida into a wart, it makes the wart go away because you're activating the immune system. So I was wondering if, because she had it actually biopsied, if that was if that instigated more rapid repair, because it was after that biopsy that she felt like it really was gradually going down in size.
That's interesting. That's why breastfeeding medicine is so cool, because it's so interdisciplinary. And I
Right.
feel like I always learn something from the pediatricians and the family practice doctors.
Right.
And
Yeah.
I have to say, I don't think I've necessarily thought of that before myself, but that's interesting. And that may make sense. I think I've always theorized that these gradually, reduce in size and symptomatology over time, because it's just the natural, a lot of these occur in that immediate postpartum period, or the first couple months postpartum, and there's just so much supply, and the breast parenchyma is so proliferative and active, and that gradually, as the milk supply drops and the just the lactational tissue settles down a little bit, I think that some of that kind of early inflammation and robust proliferative period just kind of calms down, and that the inflammation gradually calms down. I've never had one of these suddenly grow. It's always you're seeing mom, at 2 months, 3 months, 6 months postpartum. I guess the rest of you guys that in family practice get to see babies grow up, but I feel like I also do too. I see these babies that I've seen at 2 months, and then, we're seeing them back at a year still. And I've never seen one of these kind of complex, whether they're complex galactoseals or phlegmons, which again is kind of the breastfeeding phlegmon is sort of a term I've created to describe some of these complex masses that aren't simple abscesses or simple galactoseals. I think they all, you biopsy them because it's extremely low risk to biopsy these, and they often or almost always show the subacute mastitis or lactational changes, or acute on chronic mastitis, or cystic contents. You see this a lot. But yeah, maybe it does. Maybe the core needle biopsy, because they will fire the needle a couple of times, and maybe it disrupts some obstruction, disrupts some milk that's kind of lodged and sticky. I think that's something else that I learned in breastfeeding medicine is, we drain all kinds of abscesses in general surgery, and really breast abscesses are quite different in the setting of lactation. Milk is really sticky, and it's not the same kind of pus that we get from a perforated appendicitis or perirectal abscess, or even an infected sebaceous cyst. That doesn't have sticky milk in it.
Yeah, but sometimes it gets really inspissated, like when I do an IND in the office and it's just like that really super thick, cheesy stuff. It's, it wasn't always like that to begin with, right? Yeah. So I have getting away from gross stuff.
Oh yeah.
I have a question for you. Okay, so I have always said for years that I've always done this cutoff of 2 days in terms of a plug duct. So women call and they say, I have this area that's really firm, and I feel like the milk's not flowing on that side, and I feel like I have a plug. And my general rule of thumb has been to say, if it's been there for more than 2 days, come in. And some people say, well, wait, just can't a plug last longer? And to me, it's like either women get over it in 2 days, or there's something else going on. Either it's an abscess or a mass of some other sort. Do you agree with like the 2 day cutoff?
Yes.
Or, yeah. Okay.
Absolutely. It's turning into a galactosale, an abscess. I think if I could communicate to everyone that I think that I know that people have different challenges with practice situations and caseloads and schedules, but I think that the diagnosing or trying to treat breastfeeding challenges over the phone, I think that's where a lot of the trouble begins. I think that you have to examine the patient, because something that the patient is describing is not at all what you'll see with your own eyes. Something that another provider is describing is not the the same that you'll see with your own eyes, your own hands, what you, all of the, the complex dyad, what you see with the baby is not something that someone else sees with the baby. And, it all works together. And so I think that's super important to bring in any mom. And when she's calling back and she's saying, I'm massaging this plug and it's not going away, that absolutely needs an evaluation, because it's not a plug.
Right.
It's something persistent.
Right. So two other things I want to run by you. One, two things I learned from you when we were in Ottawa with the Milk Mop conference. One was you said the breast is an organ, it's not a muscle. Stop smashing it.
It's like massaging the thyroid.
Right, exactly. I think that's a great point, because all these women come in and they have these bruises and red streaks on their breast, just from, really injuring their breast from like pushing really, really hard on plugs, and or just trying to compress to transfer milk to their baby, or aggressively massaging when they're really full.
Mm-hmm.
Good to know.
Yeah, I mean, it's fat, and it's really, really dense parenchyma in breastfeeding, and I don't think it's what people imagine. I really think people think that it's almost like a balloon, and you can get the plug out at the end of the balloon, but it's so much more microscopic than that, and it really is. I think I learned so much from the physical therapists in my breast surgery training that do the lymphedema treatments, and it's a light massage, like trying to reduce inflammation and edema in the breast. We do that often after radiation therapy to the breast after a breast cancer. It's a light massage. It's not like anyone is really digging into it. As one of my patients said, digging into like a trapezius. It's not. It's the breast. Be gentle.
Right. And then the other thing is ductal sinuses. So for those of us who've been around, for a really long time, we used to rely on these images, these drawings of the breast anatomy, where there were these ductal sinuses sitting behind the areola, where the ducts are coming together, coming together, coalescing together behind the areola, and then they look a little widened behind the areola. So then this ultrasound work was done in Australia, where it was proclaimed that there aren't any ductal sinuses. And then I heard you say, well, wait a minute, let me tell you what I see in surgery.
I think, like I said, that I think most of us who operate on the breast would agree that in the retroareolar region, all of the ductal tissue coalesces, and you can see, quite dilated ducts and that's usually in the setting of a pathologic obstruction like that. That image I showed from my program director, actually from fellowship, his Henry Cure's breast surgical oncology. I think it's such a great image of a dilated duct. But I think just clinically with these breastfeeding patients, it makes sense that you would have a little bit of a reservoir there in the retroareolar region for the milk, and that they're dynamic, and and I also think clinically I see a lot of abscesses develop in the kind of periareolar, retroareolar region. I think just from stasis there, it's more uncommon to see a mastitis kind of just randomly in the axillary tail, or somewhere more distal from the the nipple areolar complex. It always kind of tends, that people tend to plug and tend to people plug in a ductal distribution radiating outward, but I think some of those more challenging mastitis and abscess situations are when the kind of the whole retroareolar area is just engorged and plugged from a particular, I think, kind of stasis and a sinus. But
it totally makes sense, because when you think about mastitis, you tend to see the little faint redness, like right at the edge of the areola, starting there. So, and also, like, if I was going to design a breast, like if I start from scratch, it would make sense that you would have like this big bulb of milk sitting behind the areola, so the baby can compress it, right? And then
exactly.
yeah.
I think Yeah.
Cool.
I guess it's up for debate, but personally, yeah, I think most of us that open up, you make a periareal incision and you open up that area, and it's certainly it's very different tissue from other parts of the breast, particularly in younger women with really dense breasts.
Interesting. Was there anything else that you want to share with the more than 1,000 people who listen to this podcast?
Geez, I guess we could just touch on quickly because I don't realize, I think when I say, of course, get imaging, get a biopsy if needed, but that a lot of primary care doctors may not be totally familiar with the terminology that the radiologists are using. And for us in breast surgery, we work so hand in hand with the breast radiologist that, knowing breast imaging terminology is it's second nature to us. But I think just a good reference, the American College of Radiology, there is a quick reference sheet that you can get at the acr.org. And you look up the BIRADS, it's called the BIRADS Atlas 5th Edition quick reference. And that has some of the language, or actually has all of the language, that BIRADS is just a standardized reporting system for breast imaging. It's called the Breast Imaging Reporting and Data System. That's what BIRADS stands for. And it was originally designed to standardize mammography reporting. So, if you're in California and you get a mammogram and then you move to, Wisconsin, someone can look at a report you had and there would be some kind of standardized referencing with terminology, and then with this the categorization of findings that you had mentioned with the BIRADS 4. So that's something that anyone should be able to look up, and there's categories from 0 to 6. Most of the time you're going to see something in the category 2 benign. Category 3 is probably benign, and that requires usually a 6-month follow-up interval imaging. And then category 4 is when you kind of get into the biopsying. But that may be helpful for primary care doctors that are seeing imaging reports and wondering what they mean. They'll always see a BIRADS score on there.
Okay, yeah, maybe I'll find the atlas and I'll post it on our Facebook page for the podcast. That sounds great. And then maybe, I don't know if you want to just mention the fact that there are these new guidelines on the appropriateness criteria for breast cancer screening.
Yes. So that came out this spring. That's an American College of Radiology appropriateness criteria that they're recommending that women who are breastfeeding or pregnant undergo essentially screening as would otherwise be indicated for their lifetime risk. So a woman at an average risk for breast cancer would begin screening at the age of 40, whether she's breastfeeding or whether she's pregnant, because the shielded uterus receives less radiation than if you were to get on a plane flight while you were pregnant. So, and then actually starting earlier screening for women that may have a known gene mutation or otherwise at high risk for development of breast cancer in their lifetime due to family history or other factors.
Cool. That sounds great. That's so this was just fantastic information, and it was really helpful to share that case. So thank you so much. And
sure. I hope it was hope it was clear. Like I said, you kind of that's actually a complicated situation. I think more often than not we see these complex masses and you're wondering, it's not quite as simple as an abscess that you drain and you move on from.
Right. And I think part of the problem is that radiology is just as stumped. And so I have found that radiology, like when the radiologist said to me, well, gosh, I really would like to know what you think about it, I realized that they really don't have a good understanding of what's happening during lactation, unless they're hand in hand with, unless they've created some sort of, protocol or system at their breast center. So, yeah, so there's a lot for us to
but I think we're all learning.
Yeah.
Yeah, I mean, I think that breast surgeons are learning, and radiologists, and I think it's one of these things that it's so complex, and the lactational changes that occur in the breast are so complex, and I don't think any of us, you only learn over time about these complicated masses and complex galactoseals and the calcifications, and it's definitely not as straightforward, and I feel like I'm learning something literally every day in my clinic. So
Yeah, and I think the big lesson is just follow, and make sure that you're not missing anything, right?
yes,
Yeah.
exactly. You can't ever go wrong. I said, congratulations to this primary care provider that sent her for imaging when something didn't look right, or there's never, it's never wrong to send for imaging or biopsy. And then to follow over time for resolution. And I think that's also something too that I see people back, and it may be a quick visit and everything may be going fine, but it's also a time to reevaluate. Mom always comes up with another question and says, oh, okay, well, what about this? I've had moms asking me about complementary foods and, all these other things that come up down the road. And like I said, I get to see babies grow up that I probably normally wouldn't get to see in breast surgery.
Right.
So.
Yeah, I know. It's so much fun to have the babies come back. Like, yes, you can come back for your breast lesion, but make sure you bring that baby.
Yeah. It's really cute.
Yeah. All right. Well, thanks so much, Katrina.
Yes.
And I'll be in touch, and we'll see you. Yeah. Okay.
Okay.
Yeah.
All
Bye.
right. Bye.
For questions regarding this podcast, contact us through themilkmob.org. We have other educational projects going on there, such as the Clinical Question of the Week and our Outpatient Breastfeeding Champion programs. If you want to see what we look like, check out our Facebook page, where you can also share comments and questions with your co-listeners. To learn more about the Academy of Breastfeeding Medicine, please visit www.bfmed.org. Thanks for listening. We'll be back with you in a few weeks.